Hello, everyone. Welcome back to the Medical Teaching Podcast for both teachers and learners. Today, I'm going to be talking about role playing and its role in teaching. So, role playing is something that I actually really enjoy doing with my learners. It kind of came about accidentally a little bit, but my teachers, at the Medical College of Wisconsin, some of them would do some role playing, especially my surgery attending physicians would role play with us in various situations. They would put us in various clinical scenarios and then say, okay, what would you do? And then I remember in residency, there were times that also my attendings would say, okay, now pretend that, the hospital, a huge tornado swept by, and then most of the hospital blew away except your wing of the hospital. And now you have to manage such and such patient by yourself. So now you have a patient who has, a heart attack, an acute MI in front of you. What are you going to do? So this kind of thought exercise, if you will, this role-playing exercise is basically to give our learners a chance to practice thinking about what to do and verbalizing out what to do in vivo, meaning as if they were in the actual clinical situation, but without any actual patients being harmed by the decisions that they make. So let me give an example here. So for instance, let's suppose that you're wanting to teach a resident about atrial fibrillation with rapid ventricular response. This is one of my favorite things to teach. So let's suppose that you're teaching your resident. Now you can teach them the standard way, right? Okay, what do you do with atrial fib with RVR? First thing you do is you decide, are they stable or are they unstable, right? And then if they're unstable, you shock them, right? If they're stable, then you find out what their blood pressure is, and you look at the EKG and you make sure there's no delta waves, and if their blood pressure is okay, then you can give them IV metoprolol, right? So you can go through it that way, and that's important to do. That's kind of the first level. But the second level is where you role play, is where you put them in the situation. And so what I'll do is I'll put them in the position where they have to manage someone who has atrial fib. So I will role play a nurse, and I'll page them, right? Okay, Dr. So-and-so, I've got a patient who's got a heart rate in the 180s. What should I do? And I have a panicked, I sound panicked, and then the resident will say, oh, well, what does the patient look like? And I'll say, well, I don't know, because I'm role playing a nurse who is panicking because they're brand new, fresh out of nursing school, and they don't know what to do, and they see this heart rate in the 180s, and they don't know what to do. So then, kind of walking my residents through, okay, what do you do? What should you tell this nurse, right? And so then the residents will say different things, and I'll say, okay, so you tell them that, and they say, I don't know. And then, so I lead my residents to say, okay, I'm going to come see the patient. Get a fresh set of vitals, get a fresh EKG, 12-lead EKG. I'll come and see the patient. Okay? That's what I want them to do. So after the resident gives a few attempts of what they think they would do, I'll say, no, these are the things that you should do. So then I say, okay, so now, resident, tell me, what are you going to do? And then they say, okay, I'm going to get a 12-lead EKG, I'm going to ask the nurse for a fresh set of vitals, and I'm going to go see the patient. I say, great. So then I'll role play to be the patient. I'll say, I will pretend to be on my phone, and I'll say, okay, I'm the patient, and I'm on my phone, and I'm playing a game. So that tells you. So then the resident sees that this patient is on the phone. They must be stable. They're hemodynamically stable, right? They're not hemodynamically unstable, right? Hemodynamically unstable doesn't look like that, right? Hemodynamically unstable looks like this, right? That's what they look like. So okay, so this is a hemodynamically stable patient. So then they are not going to do cardioversions. And I say, okay, so what are you going to do now? So then the resident oftentimes will say, oh, well, I'm going to give Cardizem 15 milligrams IV times 1 now, because they read the article. And then I'm going to wait 5 to 15 minutes and see if I need to give a Cardizem drip or not. So I say, all right. So then I'll basically then role play the patient. I'll say, okay, the patient initially, you know, after the IV cardizem, then the patient falls, slumps over, and goes into VFib. Well, why? Because the patient had WPW, and this resident didn't check for delta waves. So then the resident says, "Oh no, I killed this theoretical patient." They'll never forget. It's a very effective teaching tool. It allows them to make mistakes in a theoretical situation. It allows them, now they're going to remember from now on that after they've established that a patient with atrial fib with RVR is hemodynamically stable, then after that they're going to remember, oh yes, I need to look at the 12 lead EKG, right? And then, okay, are there any delta waves? No, there's no delta waves. Okay, then I'm going to check the blood pressure, right? Well, the blood pressure is 91/61. Oh, well, if it's 91/61, you might not want to give, cardizem or metoprolol, right? You might bottom their blood pressure, right? So you might want to give them amiodarone instead. So then the resident has to think through all these things and say, okay, I'm going to give amiodarone. Then this is one of my favorite things to do in role playing. Then they're in the situation, right? So then I'll say, okay, you give amiodarone, right? So how much and what route, right? Name, dose, route, frequency. This, in the role-playing situation, your residents will be forced to have to give the name of the drug, the route of the drug, the dose of the drug, and the frequency of the drug, right? So name, dose, route, frequency. So I just have my residents repeat that. Name, dose, route, frequency. And then I have them spell it out, right? In this case, amiodarone, 150 milligrams, IV, times 1, now. Right? And then after that, amiodarone, 1 milligram per minute, IV, for 6 hours. And then after that, amiodarone, IV, 0.5 milligrams per minute for 18 hours, right? That's the protocol. Okay, and so by doing a simulation, by doing role playing, then it allows the resident to realize what they know and what they don't know. And you as the teacher can also give them feedback and help them see what they know and what they don't know. And then you can figure out how to improve that. And so much of that comes to light so much more easily than when they're just answering questions, or when they're just saying theoretically what they would do. In the role-playing situation, they have to actually do it, right? They have to actually give the amiodarone. They have to actually give the cardioversion. And when it comes to the cardioversion, let's say the next patient, deep, deep, hello, yes, this is the nurse. I've got a patient who doesn't look good and their heart rate is in the 180s. Okay, get a fresh set of vitals and a fresh EKG, and I'll come see the patient, right? And when the resident comes, they see a patient who looks like this and the blood pressure is 70/40, then they know that this is an unstable patient. And then they're going to say cardioversion. And I say, cardioversion, great. How are you going to do that? Right? Oh, well, I need to get the crash cart. Yes, good. Get the crash cart. Good. And then what? And then put the pads on. Yes, good. You put the pads on. The tech puts the pads here and here. No. The pads here and here. Good. Yes, you should tell your tech the pads go here and here, right? If they don't put them correctly, right? Then what? Then you have to turn the machine on, right? Then you have to set it to 200 joules. Then you have to, most importantly, press the sync button, right? And so when you go through a simulation, when you go through these things and have them actually go through the motions of what they would actually need to do, then they get a better learning experience. They get a chance to practice what they would do in the real situation and not injure any patients in the process. Now, some of you who are listening to this might say, well, that sounds like that takes a lot of time. Absolutely, it does take some time, but it's worth it. Your learner is worth it. What are you doing this? Why are you teaching? Why are you a teacher? Why are you an instructor? You're an instructor to help these medical students and residents to succeed. You want them to actually succeed, right? It's not enough for us to just lecture to them or just tell them things if they're not going to remember it as well, right? If they do a simulation, they will remember it much better. Okay, and that means role playing. So some of you might say, well, I don't like to act, or I don't really like to role play. That's fine. You don't have to like it. You don't have to be good at it right away, but you can improve, right? As teachers, we have to improve. We have to get better. We have to model for our learners teachability, right? And so if we're not good at it, then we have to practice so we can get better. And our learners will appreciate our effort that we put in. So, okay, then some of you might say, well, there's too many details. I just want them to get the big picture. I would say, absolutely, I agree. There are times that our learners need to get the big picture, especially the ones that are only so focused on the details that they never see the big picture. Absolutely, it's important for us to help them see the big picture. But at the end of the day, when it comes to certain emergencies or certain situations, for instance, if someone's acutely seizing, it's not good enough to just say, well, the big picture is we're going to have to, know what status epilepticus is and we're going to have to give Ativan. That's not good enough. In the real, actual clinical situation, you've got to know what to do. You've got to know what drugs to give, what name, dose, route, frequency that they need to give. And our learners want to be empowered with that information. And what better way to do it than to role play? So same thing with acute SVT, right? Acute SVT, you can't just say, I'm going to give adenosine. That's the big picture. I'm going to slow down the SVT. There's specific details about how to give adenosine. It's got to be in a IV that's close to the heart, and it's got to be a big enough bore that you can push rapidly and that you can have a follow-up saline flush, right? And you got to warn the patient, hey, so if you don't warn the theoretical patient, the patient says, and then they're scared to death, and then they sue they in the theoretical situation they sue the physician for emotional trauma, right? Because you didn't warn them, right? Anticipatory guidance. So how can you find what better way to unearth these situations than in a role play scenario and helping your learners walk through that? So I hope that this episode is helpful. So again, just recapping, the main points are: number one, make sure that your learners know the raw facts, but then number two, to role play them and to put them in a clinical scenario where they have to know name, dose, route, frequency, and where they have to actually do and look for the things that they need to actually do with the management. And in doing so, the primary benefits are that your learners will remember it better, they'll retain it better, they'll understand it better, and they will be more well equipped for a real time, real life clinical scenario when it occurs. Hope that's helpful, and I'll catch you on the next episode.